we're going to be going over today is that we're going to be going over like what cervical disc pathology is, what are the causes pathomechanically wise, of what happens within the spectrum of pathology, as well as the different signs, symptoms, functional limitations, and the various tests and measures for this, as well as look at the different differential diagnosis, discuss the overall rehab process and phases and outcomes, and give an overview as well. So, what is cervical disc pathology? So, from the research that we did, we found out that it's like a broad spectrum of different pathologies grouped underneath this that affect the intervertebral disc within the cervical spine. One issue that can happen is the cervical disc herniation, which is usually the mean age is around 50 years old. You also have cervical degenerative disc disease. The disc can bulge within the cervical disc. You also have cervical spondylosis, which is like a condition where the cervical disc like wear down over time due to age. Another one is cervical myelopathy, which where you have compression of the spinal cord. And then the one that we found in Dutton that mainly talked about was cervical disc radiculopathy, and how Dutton defined cervical radiculopathy is that he said that this condition occurs on the cervical nerve root and is most commonly caused by a disc herniation or space occurring lesion resulting in nerve root inflammation, impingement, or both.
To start with some pathomechanics, first we got axial compression, and that just refers to the directed vertical forces through the spine. An example of axial compression could be improper weightlifting, carrying something heavy on your head, and even poor posture. Poor posture, especially like forward head posture, that's common in people who work like desk jobs that may place additional stress on those cervical discs. Then we have facet joint dysfunction, and that refers to problems in the the hip guide and ligament movement between your vertebrae. Several factors may contribute to facet joint dysfunction, such as aging. As we get older, the cartilage that lines the facet joint may wear down, and which may lead to degeneration of the cartilages that may cause those bones to eventually rub together. Rapid hyperextension or hyperflexion, that can be a result of whiplash, and that causes excessive stress and inflammation on the cervical facet joints. Then we have any abnormal spinal curvature can affect the way those facet joints bear weight, which may lead to uneven loading or dysfunction. We got microtrauma and macrotrauma. Microtrauma is small repetitive stress, and it's often a result of like manual labor, even frequent weightlifting or improper weightlifting, and all of that may place additional stress on those intervertebral discs. Then we have macrotrauma, and that's just like one single high impact event that may cause immediate damage to those structures like whiplashes and other. So some signs and symptoms. We have neck pain, obviously. That can be caused by degenerating or a herniated disc that causes inflammation or irritation, which leads to pain. We have radicular pain that is caused by herniated disc. They can press on nearby nerve roots, and that causes pain that radiates from the neck into the shoulders, even into the hands. Then due to the compression of those nerve roots, the person may experience numbness and tingling, as well as some muscle weakness due to the disruptive signals responsible for that muscle control. We have headaches. They can be due to irritated nerves and muscles connected to the base of the skull, which may lead to cervicogenic headaches. We have muscle spasms that are due to muscle tightness that can be in an attempt to protect the area. Then we have some functional limitations. Of course, reduced neck mobility, physical exercise, and ADL difficulty due to tightness, stiffness, and pain. A person may also struggle with gripping due to the compression of the nerves in the cervical spine.
So one of the testing measures we focused on was range of motion, which as you can see, we do cervical flexion, extension, cervical lateral flexion, and cervical rotation. I also included the ranges of motions just to know that like when you're working with people with these type of pathologies to know like what would be normal and what would be abnormal based on like what limitations that they may have. You can also do it passively as well as what I have here. This is like showing them doing passively into cervical lateral flexion.
Alright, so we have some more testing measures, such as manual muscle tests and muscle selective tension testing. You may want to manual muscle test capital flexion extension, cervical flexion extension, isolated sternocleidomastoid, just testing for muscle weakness, even compensation elsewhere. You can have some special testing. May include the Sperling's test, the foraminal distraction test, the Salvage test, swallowing test, and even your vertebral artery test. We'll talk about the Sperling test first. It's used to assess cervical radiculopathy, which is common when cervical nerve roots are compressed due to a herniated disc. As you see in that picture, the patient's head is tilted to one side, and an axial pressure is applied to compress the cervical spine and narrow the intervertebral foramen. If there is radiating pain into the arm on the side where the head is tilted, then that's a positive sign that that nerve root can be compressed. The foraminal distraction test is next, and that observes whether the compression of the cervical spine relieves symptoms, and that may suggest that the nerve roots are being compressed. Then you have the Salva maneuver, and that's done by instructing the seated patient to take a deep breath and literally bear down like they're having a bowel movement. And that maneuver can increase pressure on the spinal nerve and the cervical disc, which could produce symptoms like numbness and tingling. And then you have your swallowing test, and that's just done by asking the patient to swallow. And discomfort in your neck during swallowing may indicate a potential herniated disc, which could be affecting nerves or other structures. Last, we have the vertebral artery test, and that's just assessing the integrity of the vertebral arteries, which supply blood to the brain. If those arteries are compromised, then a clinician may not want to perform like manipulations due to possibly restricting blood flow further. To perform that test, you have your patient supine, your clinician, or you would extend the patient's head, rotate, and lateral flex it to each side. You would observe your patient for symptoms such as dizziness, blurred vision, slurred speech, amongst many other things.
For our last slide for testing measures, if other than like special testimony, you would want to get like scans with like an MRI, CT scan, or X-ray. And then so for some differential diagnosis, we compared it to from what we found in Dutton. It was like a lot of like different kind of like radicular type of pathologies, brachial plexus being one of those. Nerves can get entrapped within this area, especially those that like go down the upper limb. Ones like the ulnar nerve can become weak. You can have schwannomas, which is tumors at the swan cells. You can also have meningiomas, where you'll have tumors within the meninges. Tumors also within the vertebral bodies. You can also have brachial plexus neuritis. So with the brachial plexus disorders, from what we found within Dutton was that they can be confused, of course, with the radiculopathy, which is one of the aspects under cervical disc pathology, but also with the brachial plexus disorders, it can have like a burner or like stinger-like sensation, which results from traction or compression that occurs to the brachial plexus or cervical nerve roots. The other one that can get commonly confused with is brachial plexus neuritis, which this can be viral, as well as when people come into clinic with this, they usually present with like pain that resolves with a lot of
phases have some overlap. All three phases, you do patient education, let them know why you're doing what you're doing, how it will benefit them, and of course, nothing happens overnight, so you would educate them on that. In this first phase, the mass protection, the patient may be in a stabilization, collar, or brace, so you may not be able to do much with your patient initially. Maybe some gentle range of motion, depending on if they have a order from the doctor, depends on what they will allow them to do in that first phase. Of course, all three phases as well, you would do like modalities to reduce pain and any inflammation they may have. Moving on to the second phase, you can progress to maybe some strengthening and stretching exercises, whatever you see that may benefit your patient, maybe some mobilization treatments. And then that last phase is more like a chronic type phase where you're just helping them get back to doing whatever it is they like to do as far as their ADLs and occupational tasks. And of course, more strengthening, stretching, just whatever you see will benefit them in the long run.
We also included some different surgical procedures based on like all the different pathologies that fall under cervical disc pathology. People that would usually need surgery would be for those that have like a lot of like persistent pain within their neck. They could have extreme weakness as well as a lot of like different neurological defects, that being radiculopathy, myelopathy, spondylosis, and stenosis. And we listed a few surgeries that we found within Dunton. One of it is the anterior cervical disc dissectomy infusion, which is what this is a picture of right here. It's some of the discs. We also have the anterior corpotomy infusion, the laminectomy, and the rhinoplasty. So just to talk about some of these surgeries a little bit, if you're doing the anterior cervical disc dissectomy infusion, this is going to be, of course, for herniated discs. They do go more anteriorly for approaching it, even though complications aren't common. Some complications can occur. They could have a sore throat, hoarseness, they could have issues with swallowing, they could have bony fusions, as well as smooth fibrosis. And some disadvantages to this surgery could be that they could have further degenerative changes that could lead to them having to have more surgery in the future. The next one is the anterior corpotomy and fusion. Again, just like the other procedure, it's also approached anteriorly. And in this procedure, the discs are going to be incised and like moved from the back, from the posterior longitudinal ligament. And in doing so, the strut graft, which will be used to put within the space to help with keeping the neck trying to buckle from forward, is put here during this procedure. And after this surgery, people usually have to have a cervical orthosis to keep their neck in place. Then for the laminectomy, that usually will be if they have like stenosis within the area, and this helps them with increasing overall axial space here within the cervical spine. But some complications can occur if you go more posteriorly. There could be instability. If they have issues with kyphosis, they could have myofascial pain as well as an occipital headache at the back of the head. And then lastly, for the laminoplasty, usually this is if they have like a multilevel mixture like spondylitic myelopathy within the cervical neck. So the best procedure under this would be the anterior microforaminectomy, which helps to preserve the disc as well as the overall intervertebral space and gets rid of that lesion where it was at. Some advantages to this is that it gets rid of that mass where the lesion was, helps to keep the disc in motion there within the neck, gets shorter, and you won't have to have a fusion procedure if you go this route for surgery, and you do get back to function. So there's some disadvantages though, that even though since this is a shorter procedure though, it can cause issues with degenerative disc and have overall, when you may in the future have to have the removal of an uncovertebral joint. For our outcome, patients under this cervical pathology. Reoccurrence can occur, it depends on like what pathology that they have, like for example, like cervical radiculopathy, which is based on like age, posture, physical activity. They could have issues with upper extremity pain, shoulder pain, but as long as they follow the different areas for like extensive rehab, they can get back to functioning and being able to improve their range of motion, strength, mobility within like their daily activities.
Alright, quick overview. We know it affects the intervertebral joints in the cervical spine. There's many reasons why it could happen. It could be due to your posture, some other sort of dysfunction or micromacular trauma. It limits your functions, your ADLs, your occupational tasks. Your rehab is long, but it depends on what kind of cervical disc pathology, like she said, and it can reoccur. It just depends. Like the pain can continue, but that's why in that protection phase or last protection phase, you just helping them maintain and get back to ADL specific tasks.
These are our references.
Trey highlighted something that's very significant in the world of manual therapies, but it should apply to all physical therapists. So go back to one of your slides, I think with the pathomechanics. Yes. So pathomechanics, axial compression. And so axial compression can be detrimental when someone has a symptomatic bulging disc or either a symptomatic herniated disc. So what do I mean by symptomatic? That means it actually causes ridiculous symptoms. It also narrows the foramina that the spinal nerve roots exit. In addition to that, it also impacts spinal stenosis, causes spinal stenosis. So if axial compression is a pathomechanic, do we want to do activities or interventions with the person that will cause axial compression? No, because that can make it worse. So many times patients may have symptomatic bulging discs. They may have symptomatic herniated discs. They may have a case of spinal stenosis that's caused by osteophyte formation. And we get these patients like that, and we have to be very cautious in our rehab plan of care. Also, Trey highlighted, I'm going back to avoided axial compression. It may not be a good idea to do manipulation or mobilization techniques that encompass rotation movements, because rotation actually produces axial compression of the cervical spine. Okay, and so you most definitely want to avoid like your high velocity, low amplitude, or short amplitude thrust manipulation techniques. So for example, you get some patients may have axial compression and they go to certain healthcare providers. Certain healthcare providers don't check for that, and they go and do a manipulation, a thrust manipulation, and then all of a sudden the patient is worse, and they don't know why they're worse. They don't know why they're feeling worse. That's because they actually have a condition where axial compression makes it worse, where a high velocity, low amplitude thrust will actually make it worse because it has a component of a rotational force. So you have to also know what not to do when patients have certain conditions. Okay.